All right, we're going live, everyone. I hope we got some participants already logged on. This is great. Let me just start by saying hello to everyone. We are here with Dr. Igor Belyansky, one of my favorite, very talented surgeons. We are here with HerniaTalk Live every Sunday during the quarantine. At least we've been doing this, going over your questions. And you can follow me on all the different social media platforms. Once this is over, I'll post it all for you. But we are here with Dr. Igor Belyansky from Anne Arundel Medical Center, which is a beautiful hospital in Maryland. He is probably one of the most gifted laparoscopic and robotic surgeons that I know, but also probably within our entire hernia kind of world. So it's really a pleasure. And here you are, Igor Belyansky. Do I see you?
Hey, yeah, can you see me, Shireen?
No, I can't see you, Igor.
I'm here.
Did I lose Dr. Belyansky?
Can you see me now?
Are you there? I don't see your video. Do you see me?
I do, yeah. Let's see, let's try this
You
again.
do see me.
I do see you, yeah. Can you see me now?
I don't see you. Okay, it sounds like other people are saying, okay,
Yeah,
we'll let it go.
right.
So it's, I think I'm having problems on my side because I also, oh, there you go. I also am having problems logging on Facebook because it's not allowing me to go on. There's something wrong with our internet. I'm not sure what's going on.
I'm sorry to hear that.
So, Igor, welcome.
Thank you, Shireen. Listen, thank you for your kind words. Really kind words, and you set the bar too high, and hopefully I don't disappoint answering questions. Really nice
it's the truth.
Yeah, well, now listen, nice to see you remotely, and you know, it's when was the last time we saw each other? I think, which meeting was this? Was it, did I see you at, in Utah? No, maybe not, but it feels like it's been forever now that we've been locked away here at home in Maryland, and they just, our governor just,
I know, it's been way too long.
Yeah.
Are you going to the American Hernia Society meeting in New York?
Yeah, unfortunately, because of everything that's going on, I'm gonna, all the commitments I've made to travel now, I had to put on hold until February of next year. It's just, I think I'll have to focus on picking up and making up the missed time. I missed 9 weeks of non-operating, and it's gonna be probably at least a couple of more months until we get to normal elective volume that we had. So we're planning to start doing initial elective cases in about a week, but it's going to be slow trickle. But just because of all the commitments I have here, and because of practice, I'm going to have to skip on some of those trips, unfortunately. Yeah.
I mean, you have a very, I think even volume-wise, you have very complicated patients, but also volume-wise, you're very busy, and you must be behind in terms of your normal pace by a lot of patients. It's going to take a while to catch up. Is that right?
As you know, everyone is, I think. And as you know, like what we've been doing in our hospital is we've been tiering the cases based on kind of priority. And we came to the point where we only were doing emergent and urgent cases. And the urgent cases were defined as some cases that need to go within 24 to 36 hours. And most of my patients did not fall under this definition. And so there's been a huge backlog of cases. Yeah. So I mean, I'm sure you've been faced with something very similar. All of us have been going through the same. It's not just me. It's all the surgeons, you know, nurses. You know, it's everyone's feeling it. Everyone's feeling it.
Yeah. No, I hear you. So Dr. Belyansky is. Let me ask you. When you were in training, obviously laparoscopic was already an established technique, because you're much younger than I am. But robotic was not, though, right? There was no robot when you were in training?
No, I did I assisted in very few robotic cases. Was a gentleman named, his name is Dr. Dimitris Stefanidis. He was mostly foregut and bariatric specialist, a great guy. He was just only going through his learning curve back then on a older platform, a robotic platform that was an SI platform that was available at the time. And I just assisted in the cases. It was, I didn't get to basically do any cases during my fellowship on the robot.
Yeah, no, I
Just got the
understand.
basic understanding
Yeah.
of how things worked at the bedside. That's all. Yeah. Yeah, but the fellowship I did, when I did my fellowship was 2010 to 2012. And, the fellowship, as you said, I specialized like you did in laparoscopic, or we called it minimally invasive surgery, so small incision surgery. But the guy who trained me, his name is Todd Hannaford. So I trained in Charlotte, North Carolina. And Dr. Hannaford is, at the time, it still is, very well known for his skills and ability, as well as leadership in our field. And so that's where I learned a lot of my early foundation of understanding of abdominal reconstruction. And that's kind of when I came to work in Annapolis, that's what I brought, and that's what I kind of worked to establish the last few years, being able to address some of those patients. As we probably will talk, the procedures, the interventions, they have changed dramatically in the last 8 years and continue to change. So we'll see. Maybe we can talk about it for better or for worse.
Yeah, I think it's fun. That's part of the fun part of surgery. When I trained, there was no laparoscopic match. Bruce Ramshaw had a kind of like an apprenticeship. Ed Phillips had an apprenticeship. George Fursley had an apprenticeship, but there was no match. So I basically turned my residency into a mini fellowship. And went straight into laparoscopic teaching as opposed to doing an actual fellowship. We just didn't have them back then. It was kind of hit and miss. So
exactly.
I think it makes a difference.
Absolutely.
All right. So for those of you that are here, I'm kind of unhappy that I can't get you on Facebook because of the internet connection, but that's my fault. I don't know why. We had a fire. We had like a brush fire just down the street. So there's I almost canceled today because we may have to evacuate. I live in like a fire zone. So you're lucky that I'm here, but I think it screwed up our internet. I don't know.
Yeah.
Lots of helicopters and so on. So for those of you that are joining us, we will be restricting today's talk to ventral hernias. The reason for that is Dr. Belyansky does everything. So what he really is most kind of famous for is all of his surgical techniques for ventral and incisional hernias. So I really want to take use of his time here to focus on those questions. And we had a lot of questions turned in, and we're going to have some live questions and answers. So let's, okay, here's a good start of questions already turned in. If a patient wants to see one of you specialists out of state, you or me out of state, I know you see a lot of patients from out of state as I do. Yeah. How does that work? How long do you stay after surgery? How many follow-ups after surgery? What are your thoughts there? What's your protocol for out of state or out of county patients?
Well, I can tell you things are going to change now even more because of COVID-19 of how we see patients moving forward. Right. And I think it's going to be for the better, actually, especially for patients that we're seeing remotely. What has happened in the last 2 months, and this is around the country, all of us have become experts at telemedicine visits, understanding how to set up platforms and being comfortable talking in front of a camera, asking patients questions, seeing patients in the camera, sometimes even kind of asking the patients to lift up the shirt to kind of really get a bigger picture. So, so before in the past, what I would do is, ask the patients to send all the records so I can review them. And typically then afterwards, I would just get on the phone with them. We were just getting the camera telecommunication ready, but a lot of times, they would have to come and visit me. And as you know, sometimes, especially in ventral incisional hernias, before deciding to proceed to operate. Sometimes you need to get those patients ready, whether it's lose weight, control diabetes, making sure they quit smoking beforehand, the kind of all the big things beforehand. And so, it's not a one-trip, it didn't used to be a one-trip visit. So whenever I did operate, we would usually have them stay, if it's kind of one-day stay surgery, I would still ask them to stay here for 7 to 14 days, depending on kind of how big the case is, in case there are any complications immediately after surgery, so I can manage them myself. I always have trepidation because, just like anyone else, I do have complications. Things can happen in surgery. This is real. No matter how great of hands your surgeon has, how experienced they are, those are real risks when we talk about them, no matter who they are. So I asked them to stay for 7 to 14 days, depending on what kind of the magnitude of the case, and then I see them before they leave, or a member of my team will see them before they leave. And then afterwards, those that are kind of patients who travel remotely, we can usually touch base on the phone. But now things are going to change. Now I think we're going to stay in touch with each other better. Where we can, again, one of the things we think about is also how to decrease exposure to our staff, how to keep our staff healthy as well. This includes people, our staff in the operating room and our staff in the office as well. So one of the things mandates, as we come back right now after this.
It's a growing concern. And we don't even know enough about the virus to, and we're very cautious, but we still don't know enough to be really doing exactly what needs to be done. So do you have them consult ahead of time then? So you get their imaging to kind of determine the plan of care before they show up?
Yes, for ventral incisional hernias, a lot of times CT scan is priceless. Really, looking at the images of CT scan really helps to understand the problem, the magnitude of the problem. Previous operative notes are extremely important as well to see what was done, especially in the failed hernia repairs. And so I like to review those records beforehand. So the time I have was a patient, that first meeting, I can really kind of meet the patient and also get a focused history specifically about their disease process. A lot of times trying to figure out what is, the patient presents to us was a failure. And one of the questions is like, how can we potentially make things better for you? What are you looking for us? Kind of realistic expectations. And this is the first time to set up some realistic expectations and answer questions, and then proceed afterwards.
Yeah, that's true. Do you offer like I offer what's called an online consultation. So it's kind of like telehealth in that they don't come to see me. They're often, far away, or they have insurance issues, and at least they need some kind of guidance as to what needs to be done. So it's as if they're seeing me, but they're not physically seeing me. It's all the chart, the whole chart gets sent to me with the imaging and the reports, and then I type up a whole recommendation, evaluation. Do you offer that for your patients?
Usually I don't type up the evaluation. What I end up doing, and this is really nice, what you described, but no, I usually just review it, and if I think I can help the patients, some of the things that I just don't want to waste. There's some things I think I cannot help, and I'll meet with them. I'll tell them in advance, as you're meeting me, I probably will not be able to help you, but I like the face-to-face things. And then afterwards, I just kind of give them information how they need to go. One thing you mentioned is insurances, and it's kind of one of those things that we. Unfortunately, I don't make a lot of decisions who I'm able to see. There's some patients who may have insurance that we don't accept. I am a hospital employee, so some of those decisions are taken out of my hands. I actually can't see pure cash patients sometimes. We actually had to work some of that, this year, but we can't. If they have insurance, we can't see people. So it's weird. It's maybe insurance I'm not accepting, but I can't see them. It's very frustrating. But what we try to do is try to figure out which region they're in and try to help them find a provider, which I think can be very trustworthy and can help them based on their problems.
Yeah. Okay.
Yeah.
Okay. Yeah, I agree. Okay, let's move on to. I'm going to share my screen here. I come prepared for these meetings, so Okay, next question. Can you see the screen? I hope you can see the screen.
Yes.
So the next question, we'll start with an easy one. How's that? My boyfriend has a bulging navel that sticks out quite a bit when straining. If he sucks in the belly, the navel becomes smaller. Do you think this is an umbilical hernia? He's afraid to have surgery, but his belly button is so big and really sticks out. Does he need an operation? What's your criteria for operating on umbilical hernias? Because, I mean, let's just say this sounds like umbilical hernia, most likely.
This does sound an umbilical hernia. And, I just have a frank discussion. It was if this is a young gentleman, it's at some point in his life, he most likely will need surgical intervention. If it's an easily reducible hernia, not causing pain, the first thing I want to do is just kind of give them, it's very not likely that this will cause them problem in near future. But the thing about hernias, as you know, they do grow in size over time. Things that are not symptomatic may become symptomatic, meaning pain, discomfort. Things that are not incarcerated yet, meaning where the contents are stuck and you can't push them back, they can become incarcerated and sometimes become strangulated. So, but the kind of progress to that point, it usually takes a longer time. So a younger gentleman, I'll tell him that he probably should have this, he should have this fixed at some point at his convenience. If it's not bothering him yet, it's unlikely to cause him, a need for emergency surgery in the near future. That's kind of how I would leave that. And usually kind of those that are kind of surgery averse, so to speak, and if they're not symptomatic, I kind of make sure I teach them kind of what to do, how to lie down, how to reduce this. And what I find is a lot of people after a while, those sort of hernias do become more symptomatic. They are becoming more aware. They do usually come back to have those fixed. The incidence of strangulation where you need to go to an emergency room, again, that's a rare incidence of, overall. And so it's kind of interesting. In 3 months, I had 100 patients that I need to operate on. In 3 months, how many of them did I have to take emergency to surgery? I can tell you, there's one patient that I had to go to a different hospital because she lived far away to get surgery. That's it. The rest of the people there's several people in pain and discomfort, and that's why we need to fix this, and they are at risk of strangulation, but nobody has needed in my cohort of patients that I have in my hands right now, need an emergency surgery, so kind of some things to think about,
Very good. I agree. I think nothing's more satisfying than turning an outie into an innie. It's such a simple little operation, and they get like a beautiful, especially the small umbilical hernias, you can't even see the scar. They get a nice innie. Their life is transformed. But from a quality of life standpoint, I think all the studies show, the big hernias should be repaired. That really has been shown to improve quality of life. But the smaller hernias, those watchful waiting is considered appropriate. All right.
With that in mind, I'll mention one more thing. There was a study back in 2012 out of Carolinas Medical Center, and the first author was Paul Colavita. He's an attending there right now, and he specifically looked at asymptomatic umbilical hernias and repairing them. And what he's shown is those hernias that were not symptomatic, those patients actually end up having least amount of postoperative symptoms. There's a degree of patients that may develop some kind of chronic discomfort or continue having chronic discomfort, and usually the predictor of discomfort before surgery was somebody who were having symptoms, they were at risk of having prolonged or actually persistent symptoms after surgery. And those that did not have symptoms actually end up faring better. So just also that in mind as well.
Yeah. Okay. All right, you ready for the more difficult questions? Okay.
Sure, yeah. Let's have it.
Okay, so this is your bread and butter. I had a large incisional hernia repaired with mesh. I have chronic pain. The imaging shows a lot of adhesions. My surgeon says the mesh is not touching my intestines, so it cannot be the cause of adhesions. Can adhesions cause pain after incisional hernia repair with mesh?
Yeah, so that's a good question. And the first, first of all, based on this information given this question, you would have to need to know more information, I think. And so let's just kind of assume certain things. Let's assume possibly that this patient suggesting that his mesh is intra-abdominal, inside his abdominal cavity, And so that, by assumption, then I'm going to assume that this patient probably had some kind of laparoscopic ventral hernia repair, a traditional repair, which we refer to as laparoscopic IPOM, intraperitoneal only mesh, where the mesh is inside the abdominal cavity, underneath the abdominal wall, and the surgeon uses some kind of penetrating device to secure the mesh in place. Like we use stackers, little screws that can be either absorbable or metal screws. And as well as fixation with stitches that goes through the abdominal wall into the mesh, back into the mesh, and through the abdominal wall again. And so all those, and this is one of the several repairs, minimally invasive several repairs out there that's available. So that's just because you had a laparoscopic repair does not mean necessarily that you had this type of repair. We refer to this type of repair as laparoscopic IPOM repair. So when you place the mesh intra-abdominally, what can end up happening, you can develop adhesions to it. Now, by the way, seeing adhesions on CT scan, that's, you can assume they're adhesions on CT scan, but knowing for sure that the actual adhesions, you can't really appreciate that on CT scan, whether they're true adhesions or not, because it's just impossible to tell. But when you get in, that's where you see things actually plastered against the mesh sometimes. The companies the variety of companies out there, they always, actually, as you know, they make this protective barriers to protect the intra-abdominal contents from the mesh, so they decrease adhesions, but those barriers don't look great. And, you know, multiple times, meshes I've placed myself through this approach, I've gone back and I've seen adhesions to it. Now, I hope you agree with me, majority of the time, the adhesions are not going to cause clinically significant symptoms, but up to 20% of the time, you can have some kind of significant, like visceral adhesions, like which means like adhesions of intestine to the mesh. Now, can that by itself cause pain? In my opinion, probably not. You can't, because of adhesions, you can develop a bowel obstruction or a partial bowel obstruction. And that can cause you to have symptoms during your digestive tract, that kind of, and that can cause pain, discomfort. The other pain that you can have could be muscle-like pain, especially you have multiple nerve fibers that run through the abdominal wall that can potentially have been entrapped as a penetrating fixation. So that in itself, I think, a penetrating fixation and repair really sometimes can cause people some chronic discomfort. And so, Shireen, I think you and I see a lot of patients that previously had laparoscopic IPOMs before, and they don't usually have the pain directly at the center of their repair, unless they had a recurrence. But they usually have it at the periphery of the mesh. And that's how we know, like, it's probably because of the tax adhesions. You get CT scan. If somebody had metallic tax placed, you can usually see it. So anyways, I don't want to take over here, but I can talk probably about this for 5-10 more minutes at least. You know, the question is, yeah, go ahead.
I think your point is well taken, because not all hernias that are done laparoscopically will cause adhesions, right? So that's why we need to get the operative report to see where the mesh was placed and where the dissection was. Was it in the abdomen or was it multiple layers beyond?
Yeah.
And also, yeah, in general, I would say 90-something% of the time, adhesions are not the cause of pain. Do you agree with that?
Yeah,
I think it's a
I think it's very safe to say. Yeah, I do.
Yeah, so it's an overhyped problem. A lot of people, especially non-general surgeons and medical doctors, say, "Oh, it's your adhesions," but that's not an educated statement. It's almost never adhesions causing pain.
I agree.
Okay, we have another question. This is a good one. What is the optimal BMI for operation? I have a large ventral recurrence. I have lost a lot, but I want to wait for the best outcome. So can you explain what a BMI is and what criteria, what range of BMI do you recommend your patients be in before you offer surgery?
Sure. It's so BMI stands for body mass index, and essentially kilograms over meters squared, and it's a number that gets generated. You know, I guess it depends what procedure I'm doing. The BMI by itself is just a number. I just want to stop it right there. If you ever sit in a surgical meeting, you'll see us spew out a few things that, like, and I already did that, by the way, early when I was talking about diabetes, smoking, and weight. Sometimes we have to like address those, and I think it's very important. That's really extremely important, I think, and specifically in open reconstructive procedures. And in open reconstructive procedures, the degree and the risk of wound infection and wound complications dramatically goes up if somebody is diabetic and morbidly obese and a smoker. Because what happens, diabetes and smoking affects the blood vessels that flow to heal the wound. The overweight is the excess of the sometimes subcutaneous fat, which sometimes doesn't heal well, especially when you cut through this. And it kind of predisposes you to seroma formation, sometimes wound infections. A lot of times it's just superficial, but it can extend deep into the muscle layer that then can pop open and exposing the mesh, and it really kind of complicates the postoperative recovery afterwards. So to answer the question, for open repairs, usually, again, it depends. What is the optimal? It'd be great if all my patients were less than BMI of 30, right? I mean, that'd be great, but that's not that's not our practice.
You can make it under 30. That's ideal, right?
Yeah. So that'd be nice. So BMI less of 30, if you have time, but I would really caution you while you're reaching BMI of 30, but your hernia can be fixed. There's I fixed higher BMI patients, sometimes like a 40, 45, but again, selective cases, you have to weigh the risk versus benefits. And if I think especially I can deliver it through small incisions and decrease, because with small incision surgery, you don't have the same risk of wound complications as you do with open surgery. So you can cheat a little bit on the weight, but you have to make sure you deliver that. Again, because then while the patient is losing weight, you are taking a little bit of risk of, high risk patients with strangulation and operating in the middle of the night, which outcomes of those surgeries are usually not great no matter who's operating. So I hope I answered that. BMI less than 30 would be great, but otherwise, I think I do it by case basis, and I operate in some high BMI patients sometimes.
All right, let's go to the next question. Okay, so it's another adhesion question. So if I consider having mesh removal surgery after incisional hernia repair, would that cause more adhesions? And how can adhesions be prevented after mesh removal surgery? I think there's a lot of focus on adhesions as a problem. What's your thought about that?
Yeah, I try to cool people down and just try to understand why they want their meshes out. Again, I keep an open mind to a lot of things that people kind of worry about, having foreign material in their body, things I hear. But here's the thing. If you do surgery, no matter what kind of surgery you do, you can develop adhesions. There's less chances with laparoscopic or robotic surgery, but you can still get adhesions with those surgeries. Are you going to get more adhesions with taking the mesh out? Not necessarily, but you can probably get the same amount of adhesions that were there before, except now the adhesions are going to be to the patient's tissue versus a mesh. In my opinion, as a surgeon, it's much more challenging taking bowel off the mesh than taking bowel off the abdominal wall. So technically for me, I would rather all day take adhesions of a patient forming to their own tissue versus taking adhesions off the mesh. I hope I answered that correctly, but and then the question, my most important question is, why is the mesh coming out? Why do you want the mesh out? Yeah.
So the short answer is all surgery causes adhesions. Adhesions are part of the healing process, so you want to have some. The chances that adhesions will cause a complication are very slim. So we're at the halfway mark, Igor, and
okay.
Some of the people that are on this are actually your patients, because they love you so much, and they knew you'd be on, and they made time to come on this. One of them is actually a mutual patient of both of ours. Here is his question. I was very lucky enough to be treated by Dr. Belyansky and Dr. Tofai over an umbilical hernia. Dr. Belyansky removed an umbilical mesh, and I have not had any problems after. I am, however, so he now has no mesh in there, just sutures. I am, however, a bit afraid of reoccurrence. Is there anything I can do to avoid recurrence? I have been avoiding regular exercise and surfing because of my fear. Any suggestions would be greatly appreciated.
Yeah, I mean, so here's how I go. And this isn't me. This is my opinion. Again, this is, you know, it's kind of how do you live your life? I would want to live my life to the fullest. You know, the quality of life is not the same if you're living it in fear of doing something. Um, I can tell you, you know, I'm not exactly, you know, I'm not sure what the chance is, not knowing and remembering exactly who the person is right now, and we don't need to, you know, if they don't have a hernia right now, I would live your life to the fullest. And if you're not having pain, discomfort, and do everything that you can. If you develop a hernia, then one of the specialists can always, you can always talk to them and figure out which way to address this. Yeah, sure. In theory, if you stay away from kind of any aggressive activity, then you could potentially have less chances. I mean, but here's the thing, you know, there was the, you know, again, I keep digressing, but I'll answer the question. Todd Hannaford had a great study with Will Kopp in 2000s where they placed Foley catheters in patients to
Medical students, not patients, medical students.
Medical students, actually, I think it was college students, actually. And what they've done is they measured the pressure generated by each one of these participants while they were coughing, sneezing, lifting weights, working out. And they noticed that coughing and sneezing generate the highest amount. So you can stay away from all those activities, but then one day you get sick and you generate this horrible sneeze or horrible cough, you can really put you down a wall under quite a bit of stress. So here you go. You can try to have fear and stay away from things, but I would go back and try to see if you're not having any symptoms, pain, discomfort, just go back and do your things and live your life. That's my hope for my patients.
I agree. Stay away from coughing, constipation, gaining weight, smoking, all those things that you reviewed earlier.
Yeah.
And then almost all exercise has not been shown to be very high risk for hernia recurrence. So if it's going to recur, it'll recur regardless of what you've done for whatever reason, whether it's your genetics or your tissue. But I think for like a small to medium-sized hernia, the scar tissue plus the tissue repair should be adequate. And please do surf. I mean, the weather is beautiful today in Los Angeles. You should be out there. Once the quarantine allows you, you should be out there surfing. Okay, another question for you. This is regarding umbilical hernias and diastasis recti. So diastasis recti, for those of you that are listening, it's a separation of the two rectus muscles. Your six-pack should be together, but in a diastasis is a little bit separated. So if someone has an umbilical hernia within a diastasis, what is the best approach to repair the umbilical hernia?
Yeah, that's a little bit of $1 million question. And again, I'm going to give you my opinion. Yeah, it's my opinion. And so and this is more of a technical answer why I do fix the large diastasis at the same time with a ventral hernia through the diastasis. And the reason for that is what Shireen already described, Dr. Tope described, you have a tendon that usually is about 1.5 to 2 centimeters in width. That's a normal width of the tendon. For whatever reason, whether you had a severe weight gain and then you lost weight, or whether you were pregnant and then delivered several children and your rectus muscles never went and your width of this tendon is now wide, and then you get almost this tent or cave like an alien sometimes popping out of your belly when you're doing sit-ups. That's kind of, and so diastasis can range from being very minor that doesn't need to be fixed. But once this starts getting to 4 centimeters wide, that's where I'm thinking about, and associated with a hernia, that's where I'm thinking about fixing again. So the reason I'll do it a lot of times is not just for cosmesis, but I just want to make sure to deliver a repair which long-term will have the least chance of recurrence. Because what may end up happening if you don't fix a diastasis and you fix one hernia, and I've had this many times happen to me with old eye pump repairs, old laparoscopic repairs, you end up getting a hernia just a little bit superior to where your mesh would position. A lot of times it resulted from the mesh actually tearing through through this very thin tendon itself, the attachment. So the hernia it's not recurrence, but it's a new hernia because of your mesh. And so or even a spontaneous hernia through very thinly alba. So like I try to get, if it's greater than 4 centimeters, I talk to the patients about it, and I try to get it fixed up all at the same time. And usually for those cases, I'll either do a tap approach, that's a robotic approach where we go and take the inner layer of peritoneum out, or what we call E-tap access surgery, where we go behind the rectus abdominis muscle and we're working between the muscle layers. So the mesh in both of those cases is not positioned intra-abdominally, not inside the belly, but in between, is sandwiched in between the muscle layers. That's kind of, and so that allows us, go ahead.
And then for the diastasis, how far do you go from xiphoid to pubis, like the entire length of your abdominal wall to close the diastasis, or do you do something just local work?
If I decide to fix it, then I'll do the whole thing from it. And usually most of the people that have diastasis will have it from their xiphoid process all the way down to their belly button. And that's kind of the belly button is that some women do have lower midline diastasis, but that's not frequent. That's not a lot. Now, another question is like, you know, how do you fix this? You know, people like, should you, if you're fixing this, is robotic or laparoscopic approach an answer to all diastasis out there? And my answer is no. There's some diastasis that should be still fixed the old-fashioned approach, where you do the whole kind of what we refer to in layman terms, mommy makeovers, where you take the extra skin, but you also expose the muscles outside and you bring them all back together and you kind of suture the muscles back together. The same thing that we do laparoscopically, but through an open approach, because what ends up happening when if you try to fix diastasis that's too wide, when you bring the muscles together, the skin on top of the diastasis heaves up. And if it's really wide, it doesn't go away. And it's just cosmetically, the patients are very unhappy afterwards cosmetically. And so it took, nowadays, I kind of, there's certain patients I still took out of laparoscopy robotics because of that. There's some patients that still, to look cosmetically well, they still need open surgery, in my opinion.
Yeah, I agree. You know, in Beverly Hills, we have a lot of plastic surgeons. And so tummy tucks are, you know, oh yeah, we'll do a tummy tuck. So in my practice, if they have all the indications for a real tummy tuck, a lot of loose skin, wide diastasis, then that's a good tummy tuck candidate. But if it's a male or a female that doesn't have any loose skin, but they have a hernia within a diastasis, and all of those, I think what you do as well. I do I do robotic, I plicate the diastasis as part of the hernia repair. It's actually a better hernia repair. In fact, for open, I do like a tummy tuck, like I do a diastasis closure for open too, because I feel that just fixing like a Reeve stopa, like just fixing a incisional hernia open sometimes doesn't give them a good contour of the abdominal wall.
Sure.
So in addition to doing the incisional hernia, I also do a final layer of fascial plication. I think because I operate with plastic surgeons all the time, so I like learn all the little tricks of the trade. So I throw in like a tighter repair, and I feel that that extra layer protects the underlying repair. Do you do that?
Yeah, I mean, not exactly that, but you know, the suture line that runs there, it's very important diastasis to make sure this stays intact. And the question is, let me ask you this: do you use mesh in those cases as well?
So if it's a robotic case,
yeah,
and I'm doing an umbilical hernia or epigastric hernia, so small hernia within a diastasis. If the diastasis is about 3 to 4 centimeters maximum, then and the patient's like low risk, I do not use mesh. But if it's a big guy, you know, in my part of the world, it's usually like an older guy with kind of, he was fit, but like a rounder belly. Yeah. And then he's on like girlfriend or wife number 3. And so he wants, and she's much younger. And so it's not just a belly button hernia. He also wants a flatter belly. So for those, they're tight. Those men have a tight belly. So those I have to use mesh because otherwise they'll bust through the tissues. Yeah, that's my rule.
Do you ever do the skull repair? Where you do subcutaneous dissection?
I don't. What are your thoughts about scola? That's the anterior plication.
Yeah,
so the diastasis.
So that's essentially, for those listening that don't know, it's essentially placing the stitches the same way the plastic surgeons have been doing traditionally, except doing this through small incisions. And our camera and the instruments are now in the space in between the skin and abdominal wall muscles. So we're not all the way inside intra-abdominally. And so but we don't take the excess skin aside. I think, I mean, first of all, the procedure itself was described back in 1990s and described by plastic surgeons. I think the first paper was. But I think it's a great combination for if you're doing mini punniculectomy. You know, again, this is more of a realm of plastic surgery. I do some of those procedures, but I'll do mini punniculectomy and diastasis plication with a hernia repair at the same time if I don't want to burn the retrorectus space. So I do some of those, but not often, not often. And I think they give you a better cosmetic result, though. They do have a flatter look to them.
Yes,
yeah.
I agree. The anterior plication, I tell my patients, it's always flatter and tighter than a posterior.
Yeah.
But don't they get? I just feel like the scar is big. I would like around the belly button. Because I've done the Scola approach for, you know, I had like every so often get a male model or an actor that has an epigastric hernia. They don't want a scar,
Sure.
and it's too high up for an actual umbilical open. So I go in with laparoscopically, and you know, they get a seroma sometimes. You got to put drains in if it's a big diastasis. I assume. Do you use drains?
You do have to use drains. It's yeah.
And the scar is kind of, I don't know, you can see the scar. It goes beyond the belly button. You kind of like, right?
Yeah, so you go beyond the belly button, and so the scars are kind of the waistline usually. So in that sense, you can, you know, if you're talking about, again, your patients are very different from mine, but in my patients usually don't care what their scars are. But yes, you can hide the scars kind of in the bikini line, so to speak. The key with the Scola procedure, you have to select patients very well. They're truly patients who don't need excess skin removed. And then, but what it does allow you to do, like, you know, that bulge, that subcutaneous bulge that you get when you plicate posteriorly, at least that skin flattens out. But you have to be, you're right. What do you do about the belly button? You can actually move the belly button the same way. There's tricks to that. If you're doing mini punniculectomy, you can still reimplant the belly button. You can actually, like the same way you use a level blade to cut around the umbilical, the umbilicus, you can do the same thing and place that, and again, I'm getting too technical, but one of those Alexis retractors through the hole that's created, and so you essentially create a dome, and the belly button is on the bottom, so you don't cut the belly button at the stop. So you can still reimplant it in some cases, but it's just very rarely. I probably haven't done more than 20 times the Scola repair, just because it's very rarely in my own patient population that I need to use it.
All right, you ready for the next question?
Yeah, sure.
All right. You're having fun. We were almost done. We got like 14 minutes. Okay. Okay. Let's see. Oh, this was like a technical question. When removing ventral hernia mesh, laparoscopically or robotically, how can you remove the mesh through the ports without making a separate incision?
Yes. So actually, you know, so first of all, it's a similar question. How do you introduce the mesh without, you know, making big? So we usually kind of wet the mesh, lubricate the mesh, kind of roll it like a cigar, and literally place it literally like a cigar, and place it through one of the strokers with a laparoscopic instrument. When you remove the mesh, a lot of times the mesh is a little bit stiffer at that point, especially the ones we remove. And what you can do is you can actually zigzag and create a little snake, like a little strip inside. So you have an oval mesh, so you zigzag around it, and when you pull it, it becomes a string, and so you pull it through one of the strokers without having to make a big incision. So that's what I usually do.
Yeah, I do the same. I make it more linear so you can pull it out. And you know what? If you have to cut the mesh up in pieces, that's okay too. There's no need to. It's not like it's a cancer or tumor where you have to maintain the.
Absolutely.
Okay, so this is a question about Botox. What are your thoughts on the use of Botox for ventral hernia repairs? Do you use Botox?
Right now, very selectively. I do think there is some benefit to using Botox in selected patients, especially those that have very thick oblique muscles. So anatomy-wise, again, for patients that are listening, in the middle we have rectus abdominis muscles. Just to the side of the six-pack muscles, we have 3 layers of muscles: external oblique, internal oblique, and transverse abdominis muscle. And there's some patients, and you can see them on CT scan, that have very thick developed muscles. And what happens, you have to imagine, if you're trying to close the hole in the middle, think of those muscles as springs. They kind of keep pulling. And so the thicker they are, the more difficult it's going to be to pull the whole abdominal wall back together. So we refer to this as poor compliance of the abdominal wall. So things don't pull. So in those cases, I do think, especially with more difficult cases like loss of domain, what have you, I would use Botox. The problem with using Botox, at least in my practice, is unfortunately my patients have to pay for it out of pocket. That's about $1,000 expense for them for 100 units of Botox.
Yeah.
And so insurance companies don't.
It's a lot of Botox.
Yeah.
It's a lot of Botox. Yeah.
And so now some insurance companies are starting to be more lenient. You have to send them a letter. We still don't have great success. Some of my colleagues have had much more success getting insurance companies approving Botox. I can tell you, I think that, there's some kind of interesting benefits to it potentially. Question is, do you get less pain after surgery because you kind of take that tightness off, at least initially, and the patient kind of, for the next 2 months, they walk around with a little bit lax abdominal wall. It all comes back after a while, but at least it allows the abdominal wall, the muscle layers to heal well. There's some potential benefit to that. Being able to close difficult defects that you would not be able to close without, what we call component separation, that does help. Some surgeons will argue for use of Botox to prevent doing advanced procedures like what's called external oblique releases or transversus abdominis muscle releases. Again, those are procedures that will divide one of the muscles to get things back together. But where I personally stand on it is, I think in the right hands, people who know what they're doing, actually releasing those muscles does not give up your functional abdominal wall. So to me, Botox is a great adjuvant. I would use it all the time or a lot of my patients if I could, but I just don't have access to it. And and yet even with my practice, I can get away with it without it most of the time. And in selected cases, really big cases, I still use it.
Yeah, I agree. I have my plastic surgeon connection where they get it really cheap from the reps. So I buy it off them. Otherwise, if I were to order it, I'd have to charge my patients even more. So I kind of get it on the black market. Okay, the next question
do whatever you can.
Is it's a little bit complicated. What?
Okay. I say you do whatever you can. You do whatever you can.
I know, whatever you can, right?
Yeah.
It's so expensive. And we've tried so hard to get it approved by insurance and try to be as creative as possible. And we couldn't do it. Sure. We tried multiple times. Okay, so the next patient story is a difficult one. He basically was a bad car accident, nearly died, big abdominal incision, a lot of bleeding, etc. So trauma incision. And then he ended up with a skin graft over his abdominal wall. And he was like that for 18 months. And then he had a second surgery to actually fix his hernia. They just closed it. They didn't place any mesh, what do you think of that?
Yeah, I think wide majority of the time, the hernia will come back within a year or 2 years, at least to some degree. Majority of the time, it will come back. It's, what you based on what you're describing, the type of patient, it'll come back. I think is that what happened?
Okay. So,
Yeah, I'm surprised they were able to close it primarily.
Exactly what happened.
Yeah. I'm surprised
Maybe
they were
he
able
is
to
a
close it
healthy,
primarily.
like, you know, thin patient. Yeah. You know, they lose a lot of weight with these things too. So yeah, I think the studies show at least a 50, closer to 60% recurrence rate of if you repair an incisional hernia without mesh. So 12 months later, he has another hernia, and he's due to have a TAR. So they told him, you need a TAR, and now he's worried about the implications of a TAR. Can you explain what a TAR is, why you would use it, and
sure.
His main question is, should you be worried? Is this like a good thing to get a TAR? What are the critical factors to consider before moving forward with this procedure?
I mean, so TAR or stands for transversus abdominis muscle release. It's a procedure that was described originally in 2012. It's been first done back in 2006. The gentleman who kind of, a couple of many people pioneered the procedure, helped pioneer the procedure. One of the main guys being, the name is Igor Belyansky, and another one that comes up is Michael Rosen. And of course, I think it's important to mention Todd Henneford, who laid the foundation for those guys. Now that I gave them credit, I just want to kind of talk about it. The procedure itself is complex in the sense of technically it's difficult to do because the surgeon who is doing it has to have a very good understanding of abdominal wall anatomy. And so when done well, when done by someone who does those procedures a lot, I'm talking about hundreds of procedures a year and has done hundreds before, the outcomes, I think, in those hands are going to be good in the sense of not like zero risk to anything, but you know, as far as what you worry about is damage to abdominal wall as a result of, you know, mistakes during dissection. So it's not a procedure that's, it's a low risk procedure in that sense, but when done well, yeah, in my opinion, it'll give you a very low chance of recurrence in your lifelong. As far as quality of life and functionality, again, when done well, people are very functional and have a very good quality of life afterwards. I mean, that's my opinion about this procedure. It's a long procedure. You certainly should not be shy asking the surgeon how many of those procedures they've done, and don't be shy asking how the procedures are, how the patients are doing. It's a great procedure when done well. I'll still tell you that. So why is it great? Because it kind of kills two birds with one stone. What are those two birds? And one thing is it allows you to kind of release the tendinous portion of the muscle and some of the muscular portion in order to take some of the, decrease the compliance of the down wall in order to bring it all back together. In the same step as you're doing that procedure, you're developing a very large space for the mesh to be placed in between the muscle layers. So when you get everything close together and when you heal up, if you ever need to have surgery down the road, you know, I've done those surgeries afterwards, you go back in there, that you do not see the mesh. You still have adhesions. To be honest, you still can develop adhesions to yourself because that's
very good point. Yeah, that's a very good point.
But you don't get adhesions to the mesh, and so it's easier to get back intra-abdominally inside the abdomen after this. And because the mesh can be sandwiched between the muscle layers, and again, not everyone's doing this, but from my practice and many of my friends are doing this, we're not using any penetrating fixation. We're just placing the mesh in there in this kind of this contained space. It's like kind of placing a bookmark inside a book. It's not going to go anywhere. So, and then over the next several weeks after the placement of the mesh integrates.
Yeah.
What's that? What's that?
I like that analogy. Bookmark in a book. I may use that with your permission.
Oh, please do. Yeah, I use it all the time in the office.
I use the analogy of a letter in an envelope.
That's a great one too, actually. That's a great one. Yeah.
I use that for TAP. I think for inguinal hernias, I think that makes good sense.
Yeah.
Okay, sorry, you were saying.
No, so I think to answer this gentleman's question, yeah, it's a big procedure. And so I'm not sure if we're going to talk about like complications from those procedures, but some of the complications that we worry about, kind of people who do this a lot worry about, is improperly done transversus abdominis release that results in essentially iatrogenic injury as a result of improper layers being dissected. And again, it's very easy to make that mistake during the surgery. And so then some of those patients who do develop the problems develop bulging, not in the middle now, but develop bulging on the sides. Because the new herniation happens in between the muscle layers now. So, and those procedures are very difficult to
now even more difficult to repair.
Very difficult to repair afterwards. And the functionality of our abdominal wall, which
I think your first comment is the most important, which is these revisional operations. If you have a recurrence, or if you need some complicated procedure, absolutely, that needs to be done by someone who does that on a regular basis, because it is a disaster if they injure nerves, because that's not, you can't go back with that.
No.
If it recurs, one of the questions was about recurrences. That's why I use the TAR as my kind of end stage need. If there's any other procedure that can be done to address the patient's need, I don't use the TAR, because I feel like if that fails, or if you have a complication infection, what things can happen, then you've burned a lot of bridges. But it sounds like this patient legitimately may need a TAR. A question on that, after a TAR, here's a question for you. What do you do if you can't close the anterior layer? These are very, very technically advanced questions, I must say. What do you do if you can't close the anterior layer after a TAR?
It's those instances happen very rare, and this is somebody who does this. I'm saying this is someone who does a lot of those procedures a year. I probably do over 200 of those procedures a year. And so we're talking about when you can't close the abdominal wall on someone after having done a TAR or external oblique releases. Those are the people who truly had very kind of loss of the main cases, we say. And so in those cases, and you usually prepare those specific patients for possibility of what's called bridging, at least a portion. So I end up closing whatever I can, and then let's say like the hole was this big, and all of a sudden I can get the hole to this big. Essentially, it's okay to go ahead and leave that portion not closed, but have the mesh on the inside and between the muscle layers restore the continuity of abdominal wall. So again, it's okay to leave a little bit of the gap in the muscle, but the mesh is going to be there still, kind of reinforcing. But the choice of the mesh might be different in those cases. You want to potentially use a stiffer mesh so the mesh does not bulge out in the middle. So that's kind of some consideration. That happens rarely. And so again, just leave it open. That's a question.
Yes. Totally agree with that. Absolutely. These are very difficult situations. It's not common. It's not a common problem, thankfully. Once you get to the TAR stage, you better be able to close that defect. And if you can't, then and I've had a few patients where they have those giant hernias. Those are very difficult to do.
Right.
Well, this is our last, that's it, Igor.
That's it.
We're all done.
All right. Awesome.
I want to thank you for giving me your time. I know you have family and are you opening up your office yet? Tomorrow's my first day at work. What about you?
So no, I mean, I've been working as far as mostly administrative, but I've been seeing some telemedicine visits. The clinic volume has dramatically decreased. I'm definitely seeing less patients. For example, tomorrow I have 11 patients, and usually on Mondays I would have at least 30 patients in the office. Now, the 11 patients I see, only one of them I'm actually going to see physically. The rest are going to be telemedicine visit patients. We're slowly going to restart right now. I mean, I have a backlog, like I have 60 patients posted right now over the next, we actually don't have the posting done yet, but anyways, but we're starting up over the next 2 weeks. I'm going to be operating and hopefully by July, we'll be going at least at 75% of our regional volume. You know, here's the thing, this pandemic is not going, it's only the initial phase. We're only going back to normal. For the next year and a half, we're gonna be living in a very different world, unfortunately, and we have to accept it and just roll with it at this point. Keep social distancing, most
Yes.
important. Yeah. All right, great. Thank you so much, Shireen. I hope you're safe and good luck tomorrow. What's that?
I will be posting this on YouTube as well as Facebook. And we'll be doing this again next week with the doctor that you just mentioned, Yuri Nowitzki, will be with us next week. So we'll have much more TAR related questions for him. And I'm looking forward to seeing you all next week. In the meantime, I will post this video for all of you to watch and rewatch and share with your friends. Thank you all for joining us. Thank you, Dr. Belyansky, for your time. It was really lovely. Hope you're all well and take care.
Thank you. Bye-bye, Sherry. Good night.
Thank you. Thank you. Bye-bye.